begin?
Hello, good morning.
Good morning. So,
Welcome to SNU Hospital.
okay, ready to present your case?
Yes, I prepared three Tavi cases today, and the first case is accurate neo 2. 울리는 모양인데, 음향.
I cannot see you, actually.
Then this is proctor-guided practice because until 4 cases, Boston Scientific requested us to do under proctor guidance. This is the 3rd case in Korea because I performed previous 2 cases a month ago, and this was impossible to do live because Boston Scientific policy is not permitting. Thus, I prepared this. The second case will be TAVR and TAVR. Core valve failed, thus I prepared Sapien to cure the failed core valve. Third case is reversed. Sapien failed case, and I'm going to treat her with Avalot Pro. Now I'm playing the first recorded case. Hello everybody, I'm Kim from SNU Hospital. My co-operator is Dr. Jeongyu Pan, J.Q. Pan, and Dr. Jiung Han, and Dr. Boyeon Pan, and special proctor from Munich. Okay. Then we are going to present the accurate neo 3rd and 4th case in Korea through video demo. Let me introduce the case. Slide, please. Okay. This is 82 years old female complaining dyspnea function class 3. Echo, video, CJES with mild MR and mild PR. Plus, diabetes, hypertension, hyperlipidemia were comorbid conditions. Plus, current medications, and target is severe ES, treated with Tavi. Renal function is good. Plus, the score is 4.9% in these patients. Plus, cardiomegaly, clear lung field. The focus is ECG fibrillation with complete LVDB. High chance of complete AV block after Tavi. Plus, ejection fraction is good, but the cavity is very small. The stroke volume is low. Plus, thus, even the valve area is 0.5, crash gradient is about 30 feet tall, suggesting low flow drug-related severe AS. Plus, here is aortography, spot calcification all along the aorta. Plus, annulus mean diameter is about 24.5 without calcification. Plus, LVOT similar size 25 without calcification. Plus, valve calcification is also minimal, balanced. Plus, from the height is about 13 millimeters or more, as the junction height is about 19 or more. Thus, it's good. Plus, sinus valsalva is more than 30 millimeters in left and right, as the junction size is more than 30 millimeters. It's good. Plus, annulus membranous septum length is about 3 or 3.3 millimeters. Another bad sign for complete AV block after Tavi. Plus, best angle is LAO 40, pressure 6. Plus, to summarize measurement, annulus is about 24.5, perimeter is about 77 millimeters, as the junction is greater, LVOT similar to LV annulus. Height is, coronary height is good, sinus valsalva condition is good, as the junction is good. Plus, as well we choose Neo 2 from Boston Scientific, diameter is about 77 millimeters. That corresponds to 25 or 27 accurate nail with different oversize index, 10% versus 18%. Plus, I prepared the two issues for discussion: valve type selection and size, smaller versus bigger valve. The first issue, plus, there are several problems in Tavi: durability, thrombosis, leakage, AV block, future coronary accessibility, and coronary obstruction during implantation. Thus, considering such kind of problem, we can choose one from another valve. Plus, here's my personal criteria to select one among three: Sapien 3, Accurate Neo 2, and Evident Pro. You can see the first position is most prevalent in accurate nail. For example, horizontal heart or risk of probable leakage, we prefer Sapien 3 to accurate nail or Evident Pro. But in terms of risk of AV block or future coronary accessibility, we can choose Sapien as well as accurate nail 2. In contrast, risk of coronary obstruction due to low coronary height and small size of valsalva, risk of tear, valve thrombosis, effective orifice area, risk of dissection, all favors Albert Pro as well as accurate nail. So I think accurate nail 2 has strong points from Sapien B as well as from Albert Pro. Plus, in terms of second issue, what size for this patient? Smaller valve 25 versus larger valve 27. She has complete RBBB and short membranous septum, suggesting higher chance of complete AV block. As we consider 25 small valve, but leakage is problem with small valve. And in this case, calcification is minimal, whereas leakage chance is less than usual. Thus I chose smaller valve 25 with oversize index 10%. Okay, I'd like to show the process that we went to today. Okay, we punctured.
So, Dr. Kim, maybe we need some discussion at this
Plus,
time. Do we have time
This
to
is
discuss?
root arthrography.
Yes, please.
Actually, Acro Neo is not. This is Acro Neo, or you are planning Acro Neo or Neo 2?
Neo
Neo
2.
2, okay. So we are not familiar with the Acro Neo 2, so it's a new self-expanding valve from the Boston Scientific, and I like to discuss about why we need Acro Neo 2 in this specific case, and is there any advantage over other valves? Actually, anyone here have experience of Acro Neo? If no, maybe your Cohen, Dr. Cohen, go ahead.
Yes, so I don't have any personal experience with Accurate Neo 2. I've seen some, obviously, in some other live cases. I think they summarized, fairly nicely some of the advantages here. This case, I haven't seen anything. This case would seem to me to be one that could be treated with any of the commercially available valves. I think in the United States today, we don't have the Neo 2. We would not
조금 더
hesitate to
크게
use
해줄까? 잘 안 들린다.
an Evolut Pro or a Sapien 3 for this. But I think it is, the biggest issue for this patient is, to my eye, is avoiding a pacemaker because of the right lumbar branch block. And I think if you can control the depth well with the Neo 2, then that would be great. It doesn't have quite as much radial strength as the other valves, and so it may not stretch it as much. But I think, again, these days with cusp overlap techniques, we would be very comfortable doing this also with with an Evolut or a Sapien 3. So I think this one is kind of dealer's choice to me. I'm not sure if there's one that is particularly best.
So as far as I know, the advantage of Acro Neo is the reduction of the risk of coronary occlusion. And I'm not sure this case is specifically that we are worrying about the coronary occlusion by the cusp.
coronaries are pretty high.
Pretty high.
Yeah, I mean, it does, you know, I mean, it certainly has very nice reaccess with the Neo 2, given, I mean, the frame above the valve is, you know, wide open, for sure.
But
So
I
that-
think this is a very good case for first the 5 cases.
No, it's a
Get
good
an
one to
experience out of that.
learn. I don't know. Does anybody, Kentaro, do you have any experience? Nope. Is there anyone? Nope. I think we
No,
need a European here to, I think, you know, for the.
Acro Neo just have arrived in Korea. Dr. Ashida, do you have experience of Dr. Acro Neo?
We don't hear.
I can hear.
Probably no.
Probably no. Right.
No.
Okay.
The,
So.
so we can see they're pre-dilating, right? They've got a balloon
So
there.
I'd like to ask about the sizing matter. So as far as I know, the Acro Neo is the dilatation power is not so strong, and but the smaller size of the valve selection may be associated with valve embolization. Is that not? What do you think, Dr. Kim?
Yeah, most of people first think intuitively the dilating force of Acro Neo is weaker than Evolut. But after complete deployment, the annulus level expansile force would be equal between 2 devices. The only difference is the sequence of inflation. Thus, in Evolut system, we inflate down part, low part first, while upper part is squeezed. Thus, we feel the expansile force is very, very high. But after complete release, the expansile force is distributed all across the height. This final expansile force is similar to Acro Neo. Acro Neo is reversed. It is open at the upper crown at first. The second, stabilization arch, then finally, lower crown.
Yeah.
Thus, in the first expansile process, Acro Neo is very strong in upper part,
Okay.
but final stage is very soft.
Okay.
Thus, we have some force kind of feeling. The Evolut Neo expansile force is weaker than, Acro is weaker than Evolut, but it is due to the sequence of deployment, release. Final expansile force is the same.
So a predilation strategy is different between the Acro Neo versus core valve.
Yes, Boston Society always recommend predilation. I'm not sure because it may help the early stabilization of the system.
The sizing
Of course,
the
we can do post dilatation if the expansile expansion is not complete, not perfect.
The selection of the size of valve size is different between 2 valves, predilation balloon size.
Is it also based on perimeter? Thus, I think basically it is same as Evolut system.
So, any comments? And you can proceed.
Dr. Kim, this is Jang Hanbe speaking. Can I have one question about the Acro Neo 2? Actually, there is no large outcome data in the Acro Neo 2, and so Acro Neo 2 did not cleared by FDA. But anyway, in the small series of trial data, there is a significant reduction of paravalvular leakage and permanent valve implantation compared to the other companies' devices. Is there any reason in the mechanism or structures in the Acro Neo 2 to reduce 2 kind of complications?
Originally, it is very similar to the Sapien in terms of structure near to annulus. Thus, complete AV block instance is very low as Sapien. In terms of paravalvular leakage, it was very high. Thus, in Acro Neo 2, they strengthened the paravalvular outside skirt. Thus, paravalvular leakage is really improved. It also same as Sapien, is remarkably better than Evolut. This is the 3rd case in my experience. All the 3 cases, I don't see any significant leakage, just trivial or none. Thus, Accurate Neo 2 is really significantly improved compared version.
So in the video, you don't use a rapid pacing for the predilation?
No, I did rapid pacing, but capture is not complete. Okay.
Okay.
What size balloon did you predilate with? Is that a 20, 18?
21, 20, just 1 millimeter less than average diameter.
Got it.
Professor Kim, may I ask a question?
Hi.
This is interrupt. And could you please tell us what is the main improvement of Accurate Neo 2 compared to Accurate Neo?
As I previously mentioned, outside skirt would be better, and delivery system would be softer. That is really helpful to improve the performance of Neo 2.
Okay.
It is very smooth, like it's Avalot system.
Dr. Kim, I'm Kyuk Jang. Did you hear me?
Yeah.
Do you
go
hear me?
ahead.
Which size valve do you select, 25 or 27?
25.
25.
Yeah.
10% oversizing is enough in case of the Accurate Neo 2.
Yeah, Boston Scientific recommend around 10%, but in the Avalot case, I think 20% oversizing is appropriate for Avalot. Thus, in Accurate system, I also prefer a bigger oversizing index. The limitation of Accurate Neo system is available size is just 3. Thus, it is a little bit difficult to achieve the exact ideal oversizing index. But in this case, 10% would be good.
Okay. So profile is, can you compare the profile of this device as compared with the core valve? Profile is similar?
Yes, similar. It's the same sheath.
Same sheath. Okay.
For technical issue, you can see the small spine here. This is called as a free cell. This corresponds to post. Thus, that post should be aligned to commissure to avoid contact the post to coronary ostium. Thus, if the coronary ostium is low, then we have to be care about the rotation of the free cell. Free cell should be 3. Thus, in the 3-cusp view, that should be equal on the right and left. So I turned during the advance this system for 2 free cell appear on the right and left simultaneously. That makes the post corresponds to commissure. This post is farthest from the coronary ostium.
How about non-incurve? Compared to Sapien or Evolut, do you think
Maybe it's too early to talk about that.
Yeah, you can see the free cell is a little bit rotating on the right side, and you can expect on the appearance left side here.
Okay.
There's equal free cell appearance on the left and right. That is ideal position of post that corresponds to commissure in the 3-cusp view.
I mean, there isn't a lot of metal up there, though. I mean, the cells are extraordinarily open above, in the above the valve itself. So, is that really a big issue, or is that just for perfection?
If the coronary height is very low and sinus is not wide, in that situation, we have concerned about rotation. But in other words, no problem.
Yeah.
No problem.
Thank you.
Can you rotate it once it's crossed the aortic valve? with the new X4 Edwards, you can do fine-tuning of rotation. Can you do that with the Accurate 2?
If the freeset is on the right side, you have to rotate the system on the right side, clockwise. Here. The important positioning is the marker should be at the annulus level. Here is the upper crown, first step, stabilization arch, second step. Here is low crown, third step.
It is interesting that the release of valve starts from the up and ends up with the down, with that opposite direction compared to a core valve. Is there any problem with the sheath of the valve touching the left ventricle? There is a risk of some perforation or some arrhythmia? Because the sheath is going upper side to down, you need enough space in the left ventricle.
But such kind of length, intraventricular, it's no problem. Okay. So first step, you can see the deployment of upper crown here. Here. Usually that corresponds to upper level of leaflet. This upper crown function is to just set aside leaflet. Then second deployment is a stabilization arch.
Okay, I can see that the upper cells are expanded.
Archie are deployed. At this stage, the alignment is corrected to the ascending aortic axis. That is also different from the evolute. In evolute, final stage deployment happens at the alignment tilting, but in this case, when we deploy the archie, the valve system alignment is coaxial to the ascending aortic axis. Then final stage is deployment to lower crown. Rapid rotation.
So what is the last point when you can adjust the position prior to that last deployment?
Yeah, the same. The marker is at the annulus level. So we have to be very cautious not to move the valve.
Can you manage to the implantation depth? Can you change implantation depth in this stage?
A little bit, but if the upper crown is deployed and arch is deployed, the system is nearly fixed. Thus, of course, if we push a little bit deeper, it may change, but already upper crown and arch is deployed, thus there is a minimal movement of the whole system.
So
Once again,
go ahead. Is there the opportunity to recapture at any stage up until the last deployment, or when are you committed to deployment?
that is really important question. It is not retrievable system. So it looks very simple, but it is not retrievable. Thus, we have to be very cautious during 3 steps of deployment. First, second, and final third.
But as far as the marker is aligned with the annulus, there is no risk of embolization. Is that right? No?
No.
Still, we have a risk of embolization.
Embolization
only marker
toward the
is a
upward
marker.
or downward. Upward embolization is not so possible because of the large stabilization arch.
During implantation, the rapid pacing is mandatory?
No, just for pre-ballooning. Thus, the beauty of accurate nerve system is a very stable hemodynamics during deployment, because upper crown deployment stabilization deployment does not affect the hemodynamics. And the final lower crown deployment process is very rapid, like Sapien, without any pacing.
Okay. It looks so stable in this video, right? So,
Then I remove the whole system.
but if the calcification is severe or the predilatation is not enough, there is some the movement of markers over valve and risk of embolization. Is it
Yeah,
true?
risk of an optimal positioning. Thus, pre-ballooning is very critical for the process.
So you don't like to recommend for the bicuspid valve? This predilatation is not optimal and not so optimal in every case.
If you decide to select the Evolut Pro for bicuspid AS, why not Evolut? Why not Accurate? Because when we compared in registry data, when we compared Neo 2 and Evolut Pro, the part of leakage is less, complete AB block is less with Accurate Neo. Thus, if you decide Evolut for bicuspid, you can do Evolut. You can do Accurate.
Okay, we need more experience about that. But
Yeah, of
still,
course.
I'm worrying about the importance of predilation. Predilation is very important for acroneal. That's what I understand. That in bicuspid valve is not possible in every case.
But you may not get
Yeah.
much out of it. So you're now removing the pigtail from behind. So this valve you do not, unlike the Evolut, you don't deploy this in the cusp overlap view. You work in the three cusp view. Is that correct?
Yes, yeah, three cusp view is recommended by company. We don't need cusp overlap view.
The stabilization of upper part of acute 2, what does it mean? You mean the tight contact, the upper part of acute 2 and ascending aorta? That's the stabilization of the upper part of acute 2.
Yeah, stabilization arch may contact to the whole ascending aorta if the ascending aorta size is not big enough. But in this case, ascending aorta size is big. Thus, in left side arch, contact to wall, right side, non-contact. But still, it is very helpful to stabilize the whole system's position. As you can see, there's no leakage. Of course, this case has less calcification, but this is a third case. But first, second, third case, no leakage. So I really a little bit surprised that it looks very weak in expansile force, but there is no leakage, no complete AB block. As you can see, this patient has pre-existing right bundle branch block and a very short membranous septum, but no leakage.
In this video, actually, the upper crown, upper part is not touching the aorta.
Yeah.
It's not a problem,
Not problem.
but it does not stabilize the procedure, stabilize valve during the procedure. It looks like that.
Of course, anchoring force is best, maximum at this level, annulus level.
I mean, that happens with the core valve too. Sometimes it doesn't.
Yeah,
doesn't
core
touch,
valve doesn't touch the aorta in many cases, but this valve is designed to stabilize the valve by the,
Somehow it
the
still works.
expansion of the upper part.
So, Professor Kim, this is David Cohen. Are there any cases? I mean, you've only not done very many, obviously, of this. But what anatomy or type of patient would you think would not be well suited to a neo? Are there cases where you think that's just not the right choice, other than just for size mismatch where it doesn't fit?
As I mentioned before, it is not decapturable. Thus, I think it is if the anatomy is very tough, and it may hinder optimal positioning after deployment of crown, upper crown, or stabilization arch, then we cannot retrievable. Thus, we have to deploy at the non-optimal position. Thus, if the anatomy is too tough, I think it is a little bit tricky. But in other case, it has strong points from sapien as well as from evolute, as I mentioned before in the slide. Thus, indication of accurate may be the widest, except for very severe cases, very heavy calcification, very ugly anatomy.
But the procedure looks very simple and very quick.
Yeah.
Yeah, I mean, every case I've ever seen with this device, you go, well, that was easy. I mean, that's what they all look like this. They do seem very quick, and perhaps the cases are well selected, but the results have always looked like this too.
Yeah.
So it seems like it's going to be a very good competitor for the other valve systems.
Okay. So the patient is under general anesthesia or just conscious sedation?
General anesthesia for providing you the TE image. There is no paravalve leakage.
So in the future, after learning curve, do you think this valve is doable with conscious sedation? Is that right?
Of course. Already the market share of accurate nail in Germany is very high as sapien, over evolute. Thus, I think at the present moment, the accurate nail is a self-expanding valve, as it may have a strong point against the evolute. Thus, now in the Germany, in Munich, the market share of accurate is greater than evolute in several hospitals, big volume hospitals.
Yeah, it's surprising that the market share of the accurate neo is larger than other valves. This is surprising. And, people like it.
Yeah, no, it's. I mean, the one thing we don't really have for accurate neo, either 1 or 2, is very long-term data yet. I mean, I don't think there is any series with. I think we just saw at TCT. Maybe it was the 3-year results from the original Neo 1 trial, which looked very similar to
Scope 1.
Yeah, Scope 1.
Scope 1, they compared sapien 3 and accurate neo 1-to-1 head-to-head comparison. They report 3 years results. The all death or plus stroke similar to each other. The difference is effective orifice area and pressure gradient. They are better with accurate than sapien. As always, a self-expanded valve is better than a balloon expanded valve in this orifice area and pressure gradient. The other difference is prevalence instance of valve thrombosis, frame thrombosis, which is higher in sapien, lower with accurate. It is expectable. Thus, paravalve leakage is problem in compared with the sapien 3 and the sapien ultra, but Neo 2, paravalve leakage is remarkably improved, better than evolute Pro. Thus, I think this may be the workhorse. And then in certain indications, then we have to choose sapien or evolute, because this valve is not retrievable. Thus, this is a very easy and good function. Thus, I can think this may be a kind of workhorse Tavi valve.
When,
Now we have 3 minutes. Okay.
when looking at lower part of valve, the upper pore of valve frame face the STJ junction, STJ junction. So is there any criteria, the height and diameter of STJ junction when implanting accurate neo 2? So there is chance of the...
In accurate neo, there is no limitation of ST junction height. In evolute, it should be more than 15 millimeter. In sapien, it may be better to achieve 18 millimeter height of ST junction to avoid the touch between upper frame of sapien to ST junction. Thus, in evolute system, there is no certain criteria of ST junction height.
I'm curious that why the sapien valve is associated with a higher instance of thrombosis compared to other valve
Because of structure.
structure.
Yeah, inherently, the sapien 3, the nail sinus is not wide open
Yeah.
compared to evolut and accurate nail. It is very closed valve frame. The nail sinus is very narrow. That is a point of thrombosis, as well as orifice area is a little bit narrower always.
I think we have to be a little bit careful because none of the valves have been compared head to head with respect to valve thrombosis. It's similar studies, similar populations, but not direct head to head. So I just would caution a little bit on drawing the firmest conclusions about thrombosis rates.
So previous the registry of comparing the head-to-head with the accurate neo first generation versus sapien showed the worst outcome in the accurate neo, and the accurate neo 2 is better, of course. So we need head-to-head comparison.
But I think, the interesting thing is that, yes, in the Scope 1 trial that we were just talking about, the PVL rate was substantially higher with the Neo 1 than Sapien. Yet, when we looked at the 3-year outcomes that were just presented, with respect to mortality and reintervention, they were very similar. So whatever, that degree of PVL did not seem to translate into substantially worse outcomes. It's very, very interesting data.
Dr. King, time is up, and it's a very nice case, and it's our great opportunity to see the first case of accurate neo. Congratulations. So, see you
Okay.
in the meeting.
See you.
Thank you very much. So
2 hours
I'd like to-
later.